So what I want to do now is just kind of look at the specific features for staph, all right? Now, staph, this guy, we showed him before. This is our superbug, and this is to remind you, although you may not be able to see it as well with this cape, but I'll lift it up here. It's gram-positive cocci, meaning round, in a cluster. So you can see this little guy, he's in a grape-like cluster. Now, he happens to be MRSA, so we'll talk about him in a little bit. So he's a superbug with super resistance to antibiotics. So we'll talk about him again in a minute, all right? Genus features, just like we said, they're catalase positive, got to know it. We're going to focus on Staph aureus because really what we talked about earlier for epidermidis and saprophyticus is really enough for step 1. Now, what are some of the distinguishing features of Staph aureus? Number 1, we mentioned it was beta hemolytic, coagulase positive, it ferments mannitol, and one of the things we didn't mention earlier was that you get yellowish colonies on blood agar. So I'm going to show you what some of these look like, okay? So in the first panel on the slide is the coagulase test. And the top panel would be coagulase positive, i.e. positive for Staph aureus. And the bottom tube would be coagulase negative, i.e. not Staph aureus, okay? In the middle, you can see on the right-hand side of this split blood agar plate, you can see kind of that darker zone. That's the beta hemolysis of staph, and you can actually kind of see the color there. And on the very right is an example of the catalase test. Again, you can also see the yellow color of those colonies. And then hydrogen peroxide was added, and you can see the foaming. Just like when you put peroxide on a wound, you'll see, you see all the bubbles? That's what it's from, okay, the catalase. So not that many organisms are colored. You've got Pseudomonas that's kind of green, all right, as far as clinically relevant, and Staph's kind of yellow. So colors are important. If they mention a color, that's going to be kind of important. Now, Serratia can turn red at room temperature, so that's another color, but probably much less clinically relevant than Staph and Pseudomonas. So you got to pay attention to the pigment. Where does it reside? We mentioned this before. Now, 25% of the population harbors Staph aureus in the nares or nasal mucosa, and that's really the number one means of transmission. It's also found on the skin. So as I sit here, maybe, I'm not saying I'm picking my nose, but let's just say I have an itch, and I kind of get up in there and scratch. Now I have Staph aureus on my finger. So now it's flora on the skin. Now, how is it transmitted? So just think about that. The number one means of transmission is clearly hands. So I go to shake your hand after I just give my little scratch right there, and I've just transmitted my flora to you, all right? In hospitals, that's huge. Staph is a huge nosocomial or hospital infection, and we really worry about our superbug that's multi-drug resistant, all right? So hand washing is important. Sneezing, it's in the nose. I say, achoo, and I spray you like you're in a splash zone at SeaWorld, and you all get wet. Then you can get Staph aureus then. Surgical wounds. Yeah, surgical wounds, but where do you think that comes from? The skin or the hands, all right? Now, Staphylococcus aureus is also one of the leading causes of gastroenteritis in the U.S., and it's a good idea to know what foods are associated with staphylococcal food poisoning. And so we've listed here some of those foods. They're basically very rich foods. Sometimes the boards will ask you about food. It might make you hungry in that long test, but they'll give you the symptoms of somebody with a staphylococcal intoxication, and then they'll say, you know, they went on binge eating and they ate this, and this. What most likely was responsible for their symptoms? And you'll have to say, oh, it was probably that potato salad. And they might list chicken, and they might list fish and pork and beef. Okay? So you definitely want to have an idea of the different foods that you'll find that in. Now, predisposing factors for infection. Definitely surgical infections. one of the leading causes, if not number one, of surgical infections. Okay, so that's really important. Foreign bodies. Now, this is one of my favorites. I got to be honest. Like decades ago, we had this huge issue in the U.S. where women were dying from toxic shock syndrome because of the tampons. Okay? Now you're like, I never heard of that. Yeah, because you probably weren't born yet. But what happened was, what do we like to do in the U.S. when we like something? We think it's good. Like, we have an SUV, we have the Escape, right? Then we have the Explorer. Then we have the Expedition that doesn't fit in parking places. That doesn't stop with combo meals. It doesn't stop with SUVs. We make the tampon bigger and better. So what happened? It's super duper absorbent. Now we're talking king size mattress. It can absorb for days and days. So what happens? Let's see. It gets contaminated from the skin. The skin will start getting staph on the foreign body. You'll start secreting that toxin. Remember we talked about toxic shock syndrome toxin? And that's going to overstimulate the immune system. All right? Almost, I can guarantee you almost, you'll have a question. Guarantee almost, that's good. I can pretty well say that you'll have a question on toxic shock syndrome. And one of the things I like to mention in that vignette is they may not say tampon, but they may say the patient had a recent menses. All right, that's your clue. Okay. Some of the other things listed here, neutropenia and IV drug abuse, we'll talk about in a little bit. Chronic granulomatous disease, we're going to talk about more specifically with the immunology. But what I'm going to tell you now is that patients with CGD have frequent and recurrent infections with catalase-positive bacteria. That's why it's a board favorite question, because you're bringing together an immune deficiency with microbiology, because you have to remember all those that are catalase positive, and we'll give it a little biochem, all right, because you have to know the enzyme, and that's NADPH oxidase that's missing. So just think, when I talk about catalase positive, some of the organisms that we're mentioning. Okay, as far as virulence for Staphylococcus aureus, we mentioned toxic shock syndrome. Now, I know some of you look at this slide and you're like, there's too many to learn. I agree. Don't learn them all. They're not all important, okay? Number one, toxic shock syndrome toxin. Again, you know you're going to get a case on that. So you absolutely have to know that one. Now, since staph is one of the leading causes of food intoxication in the U.S., you probably need to know the enterotoxins, okay? So I'm going to list that as number one and number two. Toxic shock syndrome toxin and the enterotoxins. Now, if you can squeeze in your brain another one, that's when you're going to look at the exfoliatins. So the scalded skin syndrome, when you have an infant that gets staphylococcal infection in their blood, it's going to make the toxin, and it's going to cause exfoliation of the skin. It basically looks like the infant's been burned. That's scalded skin syndrome. So I would probably put that as number three. Okay? Now, up at the top, we're talking about the protein A. Protein A of Staph aureus binds the FC portion of IgG and can actually inhibit phagocytosis, okay? And we'll talk about mechanisms when we get to the immunology section, but basically, if you're binding to the FC portion of IgG, it cannot opsonize that bacteria. Coagulase, we mentioned, not a huge virulence factor for Staph aureus. Here's where it's important. Let's say you have a cutaneous infection with staph versus strep. Staph, because of the coagulase, tends to be more localized. You have a boil, a furuncle, a carbuncle with Staph aureus, and that's because of the coagulase. You transfer that to group A strep, and most of those tend to spread, the skin diseases. So you'll get cellulitis, necrotizing fasciitis, and that's because of the different virulence factors that group A strep has that allow that spreading. Okay, So while it's not a major virulence factor, it helps with the localization, typically, of those staph infections. Now what I want to do is just look at some of the different diseases that are caused by Staph aureus. Okay? I already mentioned gastroenteritis. We said it was one of the, probably the most common cause of foodborne bacterial-ish gastroenteritis. And the reason I say ish is because staph gastroenteritis is what we call an intoxication. So what does that mean? That means that you did not ingest live bacteria, you ingested the toxin, okay? Now what you have to know about the toxin is, number one, that it's heat stable. So that guy in a restaurant that was cooking your food, that may have had an itch on his nose, he touched your food, the toxin started growing and getting secreted by the bacteria. Now we cook the food. The bacteria die, but the toxin stays in its virulent conformation. You ingest that food, you ingest the toxin, bam, you have a really fast-acting gastroenteritis. So anytime we're talking intoxication, that incubation period is going to be like bam, all right? You've all had this, where you go to a restaurant and you barely make it home and you're like, oh, and it's like, well, we call it double bucket. So you're vomiting right out one end and you're going diarrhea out the other end. You're not really sure which end to pay attention to, and inevitably, whichever one you choose to pay attention to is the wrong one. That's the double bucket disease, okay? Any intoxication is going to be fast like that because the bacteria don't have to replicate and then make the toxin. You're just ingesting the toxin and it acts very quickly, okay? Now, endocarditis, we mentioned earlier as part of the differential, trying to decide whether it was maybe Staph aureus or Staph epidermidis. Staph aureus is probably going to be high on your list when we're talking about an IV drug user for endocarditis. In that case, you would probably find it in all three of those blood cultures. As I mentioned before, localized types of infections, abscesses, boils, carbuncles are most commonly associated with staph. And then toxic shock syndrome. All right, now, the way you're going to recognize that it's toxic shock syndrome, again, you're going to have a patient presenting with fever. They may say scarlatiniform rash, they may say sunburn-like rash. So it looks like they've been burnt. And on their palms and soles, their hands are going to be peeling. So they get desquamation on the palms and soles. All right? Remember, they're going into shock now. So they're hypotensive. Now their organs aren't getting enough blood, and they're eventually going to go into multi-organ failure, which is followed by death. Okay? In that vignette, still, even though this happened decades ago, they're still going to mention, like we said before, the recent menses, or that, the patient had used tampons. All right, so that's something to kind of keep your eye on for a case of toxic shock syndrome toxin. Now, they can ask you what causes it. They can ask you what virulence factor of the above agent was responsible. In that case, it's toxic shock syndrome toxin. Or they might ask you the mechanism of action of the toxin. Boy, that makes it a tough question, but you recognize the vignette. You know that it's toxic shock syndrome caused by the toxic shock syndrome toxin. How does it work? It functions as a super antigen, so it overactivates the immune system. Okay? Now, not done with staphylococcal diseases. We have impetigo, which I mentioned earlier. Impetigo, like I said, could be staph, could be strep. You don't know. How do you know? Catalase. The simplest way to tell is going to be the catalase test, all right? So in this case, if it is impetigo caused by Staph aureus, it's going to be catalase positive, all right? What else? Pneumonia. We don't always talk, when we talk about our differential for pneumonia, we don't have Staph aureus on top of the list, all right? Doesn't mean it can't cause pneumonia. When you will see staphylococcal pneumonia is when something else typically has beat up the respiratory tract. You had the flu. Now you're hospitalized. So we're trying to make you better in the hospital, and oops, we gave you a staph infection, all right? And that staph infection, when you get pneumonia from Staph aureus, it is got a very high fatality rate. So again, it's nosocomial, definitely post-viral. It can be from a ventilator or respirator, and then if you had certain diseases such as cystic fibrosis or chronic granulomatous disease. Now, one of the things I'm going to mention here, and we'll talk about it kind of as we go on our travel through the different pneumonias, is that when a patient has staphylococcal pneumonia, and they're going to talk about the color of the sputum, it tends to be more salmon colored, and they'll mention that sometimes in the vignette, sometimes not. But any kind of mention of that salmon colored, which is kind of an orangey color, you might want to start thinking about Staph aureus, okay? Surgical infections, very, very common. In fact, when I had my daughter Isabella, I had a C-section. 10 days later, bam, I had a staph infection, got a seroma, and my entire C-section scar just unzipped. Back to the hospital for packing. Totally unpleasant. Which brings me to another point for Staph aureus. In addition to the tampons, wound packing, also a big clue for toxic shock syndrome, okay? Now, last on the list here is osteomyelitis. So typically you're going to see staphylococcal osteomyelitis in a child. The organism's going to get into the blood, and from the hematogenous route, it's going to get into the bone. So you have a kid that has bone pain and fever, and the number one thing you got to be thinking about is Staph aureus, unless that child has sickle cell. Then you're going to be thinking about salmonella, okay? But outside of any other comorbid conditions, you have osteomyelitis in a child, you got to go with Staph aureus, okay? Now, treatment for staph. One of the things you got to think about for gastroenteritis, if it's toxin-mediated, you're certainly not going to give antibiotics, remember, because there's no live bacteria. So the gastroenteritis is self-limiting. And, of course, with staph, like we mentioned earlier, with our little superbug, our multi-drug-resistant Staph aureus or a methicillin-resistant Staph aureus, there is a lot of resistance associated now with staph. So we worry very much about MRSA or MRSA, all right? Now, initially, you're typically still going to try drugs in that methicillin class, so nafcillin, oxacillin, but at the same time, you're probably going to test to see if that staph is MRSA, okay? You can do genetic tests to look for the MEK-A gene, which encodes for methicillin resistance, or you can do a simple culture test that we'll talk about a little bit later on. Now, we are also starting to develop resistance to the next line drug of choice. So you have a patient that has MRSA, all right? You know it's MRSA. They may tell you it's MRSA. What's the next line of treatment? Next line is Vanco. You're going to go with vancomycin, okay? But now, because we have a lot of MRSA, we're treating with a lot of Vanco, now we're starting to have vancomycin-resistant Staph aureus, or what we might call VRSA, okay? You can also have an intermediate resistant or VISA. I don't want you to think that this is the end of the road. We do have drugs that can still treat Vanco, but again, you always want to start with the least and then kind of go up the totem pole for treatment for MRSA. The treatment for vancomycin-resistant staph, the trade name is Sinercid, and I know they don't test trade names on the boards, but it's a combination therapy of quinupristin and dalfapristin, combination therapy called Sinercid, used to treat the vancomycin-resistant Staph aureus. So treatment, they definitely might ask you about because of the high level of resistance associated with staph and all of the, the recent publicity that MRSA has had in the news.